it is really bad for these people. So as a pain physician, as a dolorologist, we can help them, and we can relieve this pain. And one of the best result when we do intervention in these patients, in any of the pain condition, if you compare lumbar spine or cervical spine, when you compare it with trigeminal neuralgia, it is one of the very uh, effective intervention with a result oriented, and in most patients you get very good results. Okay, so I'm going with the presentation now. So first we need to understand what is the nerve supply of the face. So we have all the 12 cranial nerves which can cause pain, and the nerve roots also can cause facial pain. So if you see, apart from the fifth cranial nerve which can cause trigeminal neuralgia, we also have nerve roots which are coming from C2, C3, which can refer pain to the angle of the jaw and area behind the eye. So you can have eye pain, or you can have pain in just at the angle of the jaw. So whenever you have atypical facial pain, which is not very classical of uh, presenting like trigeminal neuralgia, I'll tell you what are the specific features, what you have to look for trigeminal neuralgia. But if you have pain which is only at the angle of the jaw or behind the eye, which is coming as a throbbing or shocking, then you have to think about root cause, that is C2, C3 root, which can be causing pain. And of course, you have occipital neuralgia, which can give pain like at the stripe of the back and of the head. So these are some differential diagnoses. We'll just discuss those things separately. So you know that trigeminal nerve, it has three branches: ophthalmic, maxillary, and mandible, which can cause pain in the area of the affected nerve. So if you see trigeminal neuralgia, it is one of the very common condition in India, where the patients are referred to pain specialist, many times from neurologist, from dental surgeon. So it is a sudden, unilateral, and severe stabbing recurrent pain. It is a shock-like stabbing pain in the distribution of one or more branches of the fifth cranial nerve. The classical presentation of the trigeminal neuralgia is that it will go in only one distribution. If only one branch is affected, it will not share the pain from in other distribution unless that branch is affected. So if you have V3, it will go from the ear, it will go like this, and it will go to up to the middle of the mandible. But if it is V2 also, then it can be at the cheek also and down here. So it is dermatomal distribution. Okay. Anytime you have a diffuse distribution and you cannot make out what dermatome is involved, you have to think about other causes of facial pain. So it's very classical that it is in particular area of distribution, dermatome. Always remember dermatome. The second, it can be a typical trigeminal neuralgia, or it can be atypical presentation. So usually the atypical presentation is following any tumor, which may be benign or malignant, like it can be multiple sclerosis, or sometimes there may be arteriovenous malformation, which can cause atypical pain in the trigeminal distribution. Then it is the only non-dental pain that can be managed with variety of surgical procedures. So you have various surgical procedures like radiofrequency ablation or balloon decompression, or patients who are having uh, this pain, we can do surgical microvascular decompression, MVD. And these patients are managed primarily by pain specialists as far as India is concerned. Of course, neurologists, the drug management, the neurosurgeons who do surgery. But many times, most of the time, patient goes to dental surgeons because they think that it is dental pain. So many times it is misdiagnosed, and it can cause unnecessary dental extraction up to 60%. And this can cause delay in treatment, and patient suffering is increased. So if you see many of the patients, what we are getting here, they have a lot of pain, but a lot of teeth are being already extracted, thinking that pain is coming from the teeth. So many people don't have teeth. So the presentation is classical. In classical trigeminal neuralgia, it is because of the compression of the vascular structure compression by the vascular structure at the root entry zone. That is a Gasserian ganglion where it is lying in the Meckel's cave, where peripheral and central myelin of the Schwann cell and astrocyte meet. So this is a special meeting point of the peripheral and central myelin of the Schwann cell, resulting in demyelination of the ganglion cell. So if you see the ganglion, there is a cerebellar artery is there, which is pulsating and it is causing compression. And that can cause demyelination of the sheath of the ganglion, and it can cause disturbance in the peripheral and central junction, and it can cause pain at the entry zone. If you see, women are more commonly affected than men, and it is 2.5 per 100,000 people, and in mean age is 50 to 60 years. Clinically, they have sharp shooting electric shock pain that lasts for few seconds. So it is a very typical pain where it comes and goes, and it can be repeated many times a day. So it is not very continuous kind of pain. It is intermittent. That's one of the most classical. If you have patient who has intermittent pain, you can think about trigeminal neuralgia. But if you have pain which is continuous, you have to think about other cause. Usually pain is not continuous. There's a complete remission for week or months in between two pain attacks. So it is not continuous. There may be complete remission when patient doesn't have anything. Then atypical trigeminal neuralgia have the same characteristic, but it is followed by the dull burning aching kind of pain after the attacks of the pain. It lasts for minutes to hours, then disappears, leaving a complete pain-free period. So these are very classical presentation of trigeminal nerve. If you see the site, if depending upon what division is affected in that area, patient will have pain. Usually it is unilateral. Only very rarely it is bilateral. So radiation is in the distribution of the trigeminal nerve. The character I told you, it is shooting, sharp, stabbing, electric shock. It is very severe. Sometimes it is mild. In very initial phases, it can be mild. Well, patient feels a sudden shock like, and he feels something is coming here, like electric shock. But most of the time when patient comes, they come when they are talking to us, when they are telling us what are their symptoms. When they are swallowing, they are sudden shock. They just hold their cheek or their mandible in front of us, and we can know it is a classical trigeminal neuralgia. Then duration, each attack lasts for seconds to maximum 2 minutes, but attacks can follow a rapid succession. Sometimes it comes, keep on coming. So these are some patients where you have to admit them and give intravenous injections of anti-epileptic drugs like phenytoin or something. Then periodicity, it is paroxysmal with periods of complete remission, and gradually it gets shorter. So it keeps the interval between two attacks keep on getting shorter and shorter. Provocating factor. So this is very important. When patient comes to you, they say that it is when they're eating, they're talking, they're washing face or cleaning teeth. Even when they are just drinking water, it can be painful. And in the distribution of the trigeminal nerve. Relieving factors, when they avoid the triggering factors. So all these provocating factors, when they avoid, they're okay. Some drugs like carbamazepine, it works very well. And so coming to distribution, if you see the trigeminal neuralgia, it is very rare in first division. If it is only happening in one division, you have to think about other causes. So you have to think about other diseases which can cause distribution and pain of trigeminal nerve. It is worse during the day, and only 1/3 patients report pain at the night, resulting in awakening. So sleep is usually not disturbed in this patient because triggering factors are not there during night time. On neurological examination, there is no deficit. If there is a numbness or there is a weakness in the area of the distribution of that nerve, you have to think about some other cause of the trigeminal neuralgia. Usually it is, if you have neurological deficit, it is more of a neuropathy. It is not a neuralgia. So you have to differentiate whether it is neuropathy or it is neuralgia. There may be areas of allodynia which are secondary to trigger points. So if you have a chronic trigeminal neuralgia, these patients may have mesenteric muscle trigger points. So you might treat the patient's trigeminal neuralgia, but still they may have pain which is coming from muscle. So you have to identify that, and you have to treat that also. So we had a lot of patients where we relieve the pain of shock kind of pain in the area by RF ablation, but patient still has pain which is similar to that original pain. So we have to find out whether masseter muscle is causing pain or not. Palpate from inside. You have to see whether there is a trigger point. If there's trigger point, you have to inject local and see whether pain is relieved or not. And usually we get very good relief when we are giving injection in the masseter muscle. So that is important. The gold standard for diagnosis is MRI brain with contrast. Though clinical examination and clinical history taking is gold standard for diagnosis of trigeminal neuralgia. It is a clinical diagnosis, but MRI gives you idea whether there is any vascular loop or any benign or any tumor which is malignant or benign. So you can differentiate between typical and atypical facial pain. So management, I'm not going in detail about medical management. You can always read books and see the dosage of the drugs and what drugs we use. But most commonly, what we use here is carbamazepine. It's a drug of choice. It is anti-epileptic. We can also add some antidepressant like tricyclic antidepressants, nortriptyline or amitriptyline. And sometimes we use routine painkillers, maybe opioid or non-opioids. And this is how most of the patients are managed. Almost 90% patients can be managed with this. But some patients, like 5 to 10% of patients, they may need some advanced form of therapy if the pain is not under control, or if patients' work profile is demanding that they need to be pain-free and they want to go back to their work without getting affected intermittently. So they don't want any pain during their work. So they may go for surgical treatment like radiofrequency ablation. They may go for gamma knife treatment or balloon decompression or surgical treatment like microvascular decompression. So when we do this ablations, we can RF ablation or any treatment we can do in idiopathic trigeminal neuralgia, in V1, secondary trigeminal neuralgia, intractable headaches. But contraindication is all normal contraindication what we have for any other intervention, local site infections, pathologies like depression or anxiety, or patient is having some yellow flags, coagulopathies, we don't do any intervention. So this is about anatomy. So this is your Gasserian ganglion or trigeminal ganglion. You have a ophthalmic division which is going towards the ophthalm eye. This maxillary division supply the cheekbone and the inner part of the upper part of the palate. And this is mandibular nerve which is supplying the distribution over the mandible. And trigeminal nerve, it comes out from the foramen called foramen ovale. So there are three foramen ovale, foramen rotundum, and spinosum. So foramen ovale is, you can see here, foramen ovale. This is our area of interest. So this we can see radiologically under fluoroscopy or CT scan, and we can go inside and do ablation of the nerve. It is, you can see it now, little bigger picture. So foramen ovale is what you are interested in. Okay, this foramen ovale. So sometimes if somebody is starting practice, they may get confused with the other foramen like carotid foramens or jugular vein foramens. So, or they may go in the inner ear, or they can, if they are too posterior, they can go in foramen magnum. So this is very dangerous and it can be very risky for the patients, and you can cause a lot of side effects and complications if you are not in the right area. So I'll show you some pictures so you know what exactly you are looking for. Yes, so this is foramen ovale. You should not be mistaken for foramen ovale. Coming to intervention, I'll show you a small video also, so you know exactly what we are doing. So basically, you can keep your C-arm on the head end. So you can do the corded movement of the C-arm, or you can do a cephalad, or you can go little lateral, oblique view. Okay, and lateral also is very easy from this. So you can keep on the head side, or you can keep the C-arm on the side, like what we normally do with lumbar interventions. So depending upon how you're comfortable and your operation theater setup, you can decide where to keep the C-arm. Okay, so patient is in supine position. Okay, with the neck little bit extended. You can keep it more. If you keep more extended, sometimes patients do not feel comfortable, especially when they have cervical issues also. Okay, so, so this is the perfect position. You have to fix your monitors properly, because when you're doing intervention, one of the most dreaded complication is sudden bradycardia. This is because of trigeminal cardiac reflex. So the cardiac cardiac nerves are very near to the trigeminal nerve, and if you stimulate that, there may be vagal stimulation or sometimes directly stimulation of the bradycardia, and you can have a total asystole. We had patients where when we are touching the ganglion, and patient is suddenly going in asystole. So you have to be prepared by having atropine, adrenaline, everything ready. Patient has to, you have to put nasal cannula by which at least 2 to 3 liters of oxygen is going, so that saturation is good, and you get enough time. If something happens, you have enough time for resuscitation of the patient. So these are important things. So monitors are important, cardiac ECG monitor, and so here it is. When you are doing, you have to understand what are the things you are looking on X-ray. So this is your in lateral view. This is your pituitary foramen. Okay, it is a U-shaped foramen, and if you see here, this is the tip of the clivus, and from here to here, what you have is slope of the clivus. So in here, it is a pituitary foramen, and from here to here, there is a slope of clivus, and this is petrous bone. You can see this black thing. It is a petrous bone. So if you see this line and this line, where there's a right angle, and your needle has to cross, you have to be in this area. If you're going anything posterior to that or anterior to that, you are going in wrong direction. So if you take a very good lateral view, where all these lines, you should not be able to see two lines here. The pituitary foramen should be one line. If you overlap right and left side of the bones, you can see a very nice one single overlapped line. So you have to dissect this angle at this area when your needle has to go in this direction. So this is lateral view. Okay. So if you, as you see, if you go little posterior, you can enter the eustachian canal. If you go anteriorly, you can enter in orbit, or you can enter in jugular vein or carotid artery. A lot of important structures are there. If you understand anatomy well, fluoroscopic anatomy well, there is no chance that you are going to enter any of these foramen. It is one of the safest procedure if you are entering and you are identifying foramen oval properly. So most important thing is identifying foramen oval. And this is balloon. This is a Fogarty catheter. So you can use this. I am not using this very commonly, but these are being used by many of my colleagues for treatment. Okay, so here once you keep the patients in supine position with necks extended, you have to take AP view and go little caudal till you can see a very nice foramen here. You can see foramen here. So this is very peculiar of foramen oval. It is very oval. It is soft borders, clearly visible. It should not be hazy lines like this. The boundary of the foramen oval should be smooth. There may be many openings you can see on X-ray, which may be looking like foramen oval, but when you move the C-arm little bit caudal or little bit cephalate, you may disturb the smoothness of the opening. That is not foramen oval. If the smoothness of the opening is not disturbed, when you go little down or little up, little cephalate or little caudal, then you know for sure that it is It is foramen oval. And usually when you make little oblique, the foramen oval moves towards the mandible. This is your condyle, mandible condyle. So moves little bit towards the mandible. So you need to keep it very near to the mandible, between mandible and maxilla. That is where you see this foramen oval. Once you see this, you can give local anesthetic exactly over this area, and you can insert your RF needle or balloon needle, whatever you want to do the procedures with. So this is very important in AP and oblique view. You have to identify the foramen oval, and thereafter you go with it. Okay, so just the different pictures. I'll just go with the. This is balloon. Okay, so you go up to the foramen oval opening, and then you put a catheter, and you have a radio opaque dye, and you can inject balloon and keep it for certain minutes, maybe around 10 to 15 seconds, and then repeat the procedure and till the hyperesthesia is developed. So this is about, I'll come to the complication, and this is about RF ablation. So you can see here very clearly the bony lines, they are very clear. Not, you cannot see double lines here. So that means right and left is overlapped properly. This is your tip of the clivus. You can see the bone here. This tip of clivus, and the slope of the bone is called slope of the clivus. And this is petrous bone. So when you go here, you have to dissect this angle. That means you are in right area. Okay. And this is RF ablation. I'll just show you this RF needle. Normally I use around 3 or 5 millimeter active tape for doing ablation. Okay. 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 I'll show you one video. This is the patient we did. This is a 3-minute video. So patient in supine position, you have oxygen here. Okay, you clean and drape, take all aseptic precaution. After identifying foramen oval, give local here and go inside, take X-ray. So if you see, the patient is fully conscious here. It is only under local anesthesia. We are not giving any general anesthesia as of now, because general anesthesia will not allow us to identify them. You can see this foramen oval, and now it is end-on view. Oh, in end-on view, in tunnel view, we have to go in. So we are talking to the patient. So when you are very near to the foramen oval, patient will feel some sensation of shock, like in the same distribution in V3 or V2. So here you see the needle is almost at the angle here. Okay. So under live fluoroscopy, I put the needle in. Now here, depending upon what level of the nerve your patient is having pain in. So if you have this tip of the clivus, and this is your foramen oval, the base of the clivus, the first nerve will be your V3. The second here will be V2, and third topmost will be V1. So you have to divide this slope into 3. You have to create one line here, middle one line here, and upper one line here. Okay, imagine this line. If you have a trigeminal nerve which is in V3 division, you have to keep your needle tip somewhere here in this area. If you V2, you have to keep little deep. And if it is V1 also, you want to ablate. Most of the time I avoid it, but sometimes patient is having severe pain, we have to do V1 also. I keep the needle all the way deep here at this level. So this clivus is important to identify what nerve we want to ablate. Okay, so once we place the needle properly, patient is conscious, still conscious. We have given conscious sedation, which is fentanyl and propofol. Okay, when we enter, because once patient is little bit sedated, they don't have this bradycardia. So the CSF is coming out, So that is because of in Meckel's cave, there's some CSF is there. It's collected CSF. So we can put our RF electrode and do such stimulation. Okay. And when we do stimulation, we have to wait for patient to come out from propofol effect. Then you do at 50 hertz, you do a sensory stimulation. So I ask patient in which area the patient is getting pain. So if she says the pain is coming in the same area of her original distribution, I am sure. Then I do a motor stimulation. If it is V2, we are not going to get too much motor stimulation. If it is V1, V3, we are going to get the mandible contraction because that's a more that is having a lot of motor component also. The patient is fully conscious as of now. So after that we start RF lesion. When we are doing RF lesion, we have to give again sedation to the patient because that's very painful part. So we give a little bit fentanyl. If you have already given fentanyl around 50 to 75 microgram, then you can just add propofol. The first 15 to 20 seconds are very painful for the patients. Once you ablate the nerve or ganglion, in first 15 to 20 seconds, the sensitivity start coming down. Thereafter, you don't need much of the sedation or pain for anesthesia. Okay, so you start RF lesion, wait for 20 to 25 seconds. If patient is comfortable in that area, after that, don't give much of sedation or propofol. You can wait. After that, patient is very comfortable. So I normally start at 70 or 65 degrees and see how the patient responds to it. I awake the patient again and I do a sensory stimulation again. So after one lesion of around 60 seconds at 65 or 70 degrees, I awake, I allow patient to come out. Then I do a sensory stimulation again. So initially we should get sensory stimulation between 0.1 to 0.2. That's ideal for me because that means I am very near to the gastric ganglion and when I ablate, I can get very good ablation. So if I do sensory stimulation post RF, the patient should feel some pain in the area of distribution at anything 2 or 3 times the normal stimulation pre-lesioning. So if she got sensory stimulation at 0.2, ideally I am happy after the RF lesion if she is getting stimulation at 0.5 or 0.6. That means 2 or 3 times. So that is a very ideal way or very good way, objective way of getting information from the patient whether the nerve is ablated or not ablated. Many people do touch, they do pinprick to identify whether hypoesthesia is achieved or not. But that is because patient is sedated. Sometimes they tell correctly, sometimes they don't say correctly. So I have found out that doing a sensory stimulation again and followed by motor stimulation again and identify how much delay we have caused in stimulating that nerve in the same area. That will give us effect. So we get exactly how much hypoesthesia we have created, how much lesioning we have created. So is it clear, Victor? This is very important to understand how much lesion we have done. So we do not overdo it and we do not burn it too much because if you burn it too much, you get all the complication.
El doctor está comentando que es algo muy importante. Después de hacer la lesión, obviamente el paciente despierto con muy poca sedación, inicialmente encontró el estímulo en punto 2 y posterior a la lesión espera encontrarlo hasta punto 5. Es más confiable que estar haciendo pinprick al paciente.
Right? Okay. Right. So this is what we are giving propofol and fentanyl, and always we observe the monitor. Okay, so patient is doing well here. And once we get a desired effect, we bring out the patient, the needle, and then after patient, okay, so she has hypoesthesia. You can also test with the needle later on. Okay. Okay, so this was about So always remember that at 50 hertz, we do sensory stimulation. We try to get between 0.15 to 2 volts in target dermatome. If patient is feeling pain in different dermatome, you have to pull out your needle and go back again, adjust your needle so that you get the needle tip in the exactly over the nerve which you want to ablate. So motor stimulation, and then you have to, these are the thing. So okay, so coming to complications. So in whether you're doing balloon decompression or RF ablation, usually the complications remain almost same. So there may be a dysesthesia post RF if you are doing too much of lesioning. So if you are numbing the nerve too much, burning it too much, you can get all these complications: hyperesthesia, dysesthesia, anesthesia dolorosa, loss of corneal reflex. If your needle tip is too deep and you are ablating V1 division, or sometime if you are heating it too much, if you are heating too much, you can, the heat can reach V1 division and it can cause. So you have to be very controlled. So start with the lower temperature, go high, and then you can avoid all the complications. Okay, these all complications are less with balloon, but their success rate is also less. So you have to decide pro and cons between two things. Then sometimes you have motor deficit and masseter weakness, retrobulbar or cheek hematoma, transient otalgia. Uh, some I have seen many patients with sudden ear pain coming after the, but usually they settle down after treatment with carbamazepine in 2 or 3 weeks. Usually that is because of the irritation of the nerve which is going to near to the ear. The diplopia and other cranial nerve dysfunction, if your needle positioning is really bad, so usually it is not very common. Okay. So that is about trigeminal nerve and RF ablation. Okay. So can we go to Sphenopalatine now, or you want to take question on trigeminal first?
¿Quieren hacer preguntas de lo que ya se habló del trigémino o nos esperamos al final de que ya se hable de esfenopalatino? Yo creo que al final, ¿no? Podemos hacer una preguntas y respuestas de los dos procedimientos, de las dos técnicas.
Yo creo que sí, el final estaría mejor.
Ok.
Hello, Kailash.
You can continue, doctor. We can do
Okay.
question answers at the end.
Okay. So the another nerve in the facial region, what we want to treat is Sphenopalatine. Sometimes it can cause neuralgia. Okay, that is not very common compared to trigeminal neuralgia, but blocking Sphenopalatine ganglion sometimes is very handy, and it gives us a lot of confidence to treat facial neuralgia, because many of the sympathetic components are coming from the Sphenopalatine nerve. So if you see the anatomy, it is lying in the pterygopalatine fossa. It is not very big. It is 1 centimeter wide and 2 centimeter high. It is lying in inverted flower vase. So I'll tell you what is that. So when I come to the picture. So if you see the face, the bony structure, so you have this pterygopalatine fossa. So we see the roof, it is greater wing of the sphenoid. Anteriorly, there is a maxilla here, and posterolaterally is pterygoid process of the sphenoid. And medially, there is a vertical plate of the palatine fossa. You can see this here, vertical plate of palatine bone, and floor is horizontal plate of the palatine bone. So it is, if you have to imagine it in 3D way. Okay, so this is roof, medial, lateral, and anterior lateral. So the Sphenopalatine ganglion, it is lying in the pterygopalatine fossa, okay, or Sphenopalatine fossa. So if you see that it is also connected to trigeminal system, where the V2 division, which is coming and it is flowing over the pterygopalatine fossa, it gives small nerves. These are called pterygopalatine nerves. These pterygopalatine nerves, they hold the Sphenopalatine ganglion in the fossa. So it is basically hanging with support of pterygopalatine nerve. and there's a palatine nerves behind, the small nerves which are going towards the palate. So the pterygopalatine ganglion, it has the sympathetic and parasympathetic roots which reach the ganglion through the nerve of pterygoid canal, which is formed by union of the deep petrosal nerve and sympathetic, which are sympathetic, and greater superficial petrosal nerve, which are parasympathetic. So it has sympathetic component as well as parasympathetic sympathetic component. So these are the greater superficial petrosal nerve, which are parasympathetic, and these are deep petrosal nerve, which are sympathetic. So these are giving sympathetic and parasympathetic supply. So this is the reason many times you have patient with sympathetic symptoms, uh, you can think about giving a sphenopalatine ganglion block. So the lacrimal gland is very important. The normal autonomic pathway, when you see the pterygopalatine ganglion, it is the V1 and V2 which is communicating with the lacrimal gland. It is very important. So many times we see in the sphenopalatine ganglion neuralgia, patient is having a lot of ocular or lacrimal symptoms. It is all because of the nerves, the sympathetic nerves, which are passing through this ganglion and going from V1 and V2 division to the lacrimal gland. There may be a direct variation where the sympathetic ganglion is directly supplying the lacrimal gland. So this is why the patient is having a lot of lacrimal symptoms without having any pain in V1 or V2 division, and which represent a very atypical, diffuse pain in the face, and as well as lacrimal symptoms. So this is one of the signs which you have to identify when patient is taking the history of the patient, what symptoms patient is having, and you can identify that the diffuse pain, lacrimal symptoms, and patient is having not able to identify where the pain is, what is causing the pain. So he cannot identify, it's a diffuse pain, atypical pain. So what this fossa, the pterygopalatine fossa contain, it apart from ganglion, it is a maxillary artery, its branches, and there are median nerves. And it is connected, as I told you, to median nerve, pterygopalatine nerves, and greater and lesser palatine nerve. So we see these are the uh, pterygopalatine nerves, and these are palatine nerves, which are going to the palate. Okay. So if when you are doing, your needle position has to be perfect. If you are going too much, this is inverted vas. So if you see this area from here to here, so it is like this V, inverted is the inverted vas. Okay. So you have, if your needle tip is little above, you can ablate the pterygopalatine nerves. So you can have a sensory deficit in the area of the supply of the V2 division. And if you are below, if you are not going at the ganglion level, if you are a little below, your needle tip is little below, you can cause palatine hypoesthesia and ganglion will not be affected. So position of the needle is very important here. So sensory supply to the nasal membrane, soft palate, and some part of the pharynx. And autonomic, I told you it is sympathetic and parasympathetic. So what are the indications? So if you see a lot of their papers on it, and you can see that the indication, right, most commonly is sphenopalatine neuralgia, trigeminal neuralgia, which is not responding to other management, RF ablation, surgery, medical management, everything you have tried, and patient is not relieved. Then you can try sphenopalatine ganglion block. For migraine and cluster headache, which are resistant to the treatment, you can try this. Patient with atypical facial pain, you can try this. Herpes zoster ophthalmicus, where you don't want to ablate the V1 division. And anyway, we don't do RF ablation where patient is already having neuropathy. Herpes zoster causes neuropathy because it damages the myelin sheath of the nerves. So you try to do sympathetic nerve block for these patients, and cancer patients where facial pain, you can try this. So what are the symptoms? It can cause unilateral facial pain at the root of the nose, and it starts somewhere. Patient feels something here, and then it goes to zygoma, sometimes to the mastoid, sometimes go back in the occipital area. And as I told you, there's a lot of lacrimal symptoms. Rhinorrhea is there. So what is atypical facial pain? When you want to use sphenopalatine ganglion neuralgia, nerve block for atypical facial pain, you have to know what is atypical facial pain. So it is unilateral, constant, difference between trigeminal neuralgia is that is intermittent with a pain-free interval in between. Here it is unilateral and constant. There's aching, burning, and not confined to any cranial nerve distribution. May involve entire face, scalp, or neck. Okay. And contraindication, already we have discussed about this. In any intervention, local infection, coagulopathy, very anatomy variation, and rule out before the block whether patient is having paranasal sinus infection, because you don't want to introduce infection in the pterygopalatine fossa, which is very dangerous because it's very clear, very near to the brain. It can cause infection going in the brain, and it can cause a lot of issues. Nasal deformities and trigeminal neuralgia has to be ruled out. So basically, we use a 10 centimeter curved RF needle with 5 or 10 millimeter active tip. Normally, I prefer 5 millimeter active tip, and you need to have contrast. You need to have local anesthetic. Sometimes I inject steroid also before doing RF ablation, because it can, if it is a some inflammation is there, it can relieve the pain by steroid itself. And all monitors, patient is in supine position. So here your patient is exactly in supine position, and you always do in lateral view. Start with the lateral view. So you have to identify this pterygopalatine fossa. So now it is little complicated. It is not that easy, but the simplest way you can identify your zygoma is there. You have a maxillary sinus is here. Your orbit is here, and you have to overlap right and left maxilla. Okay, and you have to overlap right and left zygomatous bone. Then you have to identify the most posterior border of the maxilla and the lower border of the zygoma here. And this is your inverted vas. Okay, so you can see here. This is the area. Okay, so this is not easy, because when you first time you do this procedure, you cannot identify anything, because sometimes your alignment in lateral view is not correct. Sometimes you don't identify what is seen, but if you read properly, you can actually see what you want to see. The radiology is very important. I always tell my students that once you know what you want to see, then you always try to see that part. You ignore other things. So try to uh, learn radiological anatomy first before you go for this procedure. And in AP, your target is you have to reach somewhere here in this area. Okay, you don't have to go too much up or too much down. Okay, very near to the nasal bone. So lateral border of the nose, you have to reach somewhere here near. Okay, and of course you have to do stimulation, so you know exactly where you are, whether you are stimulating the right area or not. Okay, and one more thing, the entry point. So you have, this is your condyle of the mandible, this is mandibular notch. Okay, and you exactly enter here. So what do you, when you from lateral you are going, your needle direction is medial, and you are going little anterior. So you go little bit, take AP view, see whether your needle is progressing or not, because this is not an end-on procedure where needle is going in tunnel view. It is not that procedure. This is the procedure where your needle is going in different direction. Your C-arm is, you have to use in AP and lateral very frequently, so that you know whether your needle is progressing medially, and at the same time in lateral view, you are going exactly over the sphenopalatine fossa.
I think this is the difficult part of the procedure, right, doctor?
Yeah.
It's not a...
It's very, yeah, very difficult, because it is not a tunnel view. It is you are going in tangential direction. It is you are starting here, and you can see your entire needle. In tunnel view, you are exactly over the structure you are targeting, and it is you are dropping your needle directly over that area. But here you start at the notch and then slowly progressing. So when you go 1 or 1.5 centimeter, take AP view. Okay, in AP view you should be able to. So if you start here, if you go 1.5 centimeter, your needle will go somewhere here. So you have to match your lateral view, AP view with your movement. So if in lateral view you have gone inside by 1.5 centimeter, but in AP view you are still here, that means you are not going in the right direction. So you need to change it to little bit anteriorly. So you in lateral view where you're going, if you're going like straight like this and your needle is not moving in AP direction, you have to come out, change it, go more anterior. Can you understand this, or it's difficult?
Yeah, but do you recommend curved tip needle?
So this is your mandible. Okay, can you see this mandible? So you start here. You cannot start directly over the ganglion. Can you see my arrow here?
Yes, we can see the arrow.
Okay, so this is notch of the mandible. Okay, so here you have to start somewhere here, just anterior to the posterior condyle, and then you have to go medial and anterior. So you have to go little anterior. Okay, your needle direction is anteriorly here. And when you go little bit in, you have to take AP view. From lateral, you enter your needle in lateral view and change it to AP view. In AP, you have to see that needle is moving medially. If it is not moving medially, that means you are going posterior. Okay, so your needle has to be little bit anterior and little bit cephalate. So it is you are starting here and you're going cephalate, medial, and anterior. So this is starting point. What is anterior? Anterior is this area towards the nose. What is cephalate? Cephalate is this. And what is medial? Medial is this again. So needle here, see, you can see this arrow. This is exactly the direction. You go anterior, that means toward the nose. You go cephalate, and you go medial. Okay. So I know it is difficult. So most important thing to identify is the inverted flower vase. So that is where your needle tip has to be. You can use CT scan if you have difficulty. You can take advantage of your radiological colleagues' anatomy knowledge, and you can do under CT scan guidance. So once you reach the pterygopalatine fossa, you can inject around 0.5 to 0.75 ml of the anesthetic. If you are doing a therapeutic block with steroid, you can use little larger volume because you are not worried much about diagnostic value of that. But if you want to see the diagnostic value, then inject very small quantity of 0.5 to 0.75 ml of local anesthetic. This is your needle direction. Okay. And if you see here, so this is your inverted vase here, and your needle tip has to be somewhere here in this area. So you can see two lines here. Okay, so when you start here, this is your mandibular notch. When you start here, you have to reach here. So when you cross this line, you try to do sensory stimulation here. Okay, but if you are crossing this line, there is a chance that you are entering the nasal cavity. Okay, so you don't have to cross this line. There are two lines you can see. Okay, so you don't want to enter the nasal cavity, so you don't cross this medial line or anterior line in lateral view. So you cross this and stay here, and in this area stimulate. If you are too much up, you can ablate the maxillary nerve. If you are too much down, you can ablate the palatine nerve. So you have to be somewhere here. This is the target. Okay, can see? Can you see this? Okay.
Yes.
So this you can see entire length of the needle. This is the one procedure where you are not in tunnel view. So this makes it very technically very difficult. But once you get the knack of it, you understand where you want to go. and it needs some practice. It is not, you see the patient try to do it one or two. If I have some video, I'll share with you. Because right now I don't have any video. If I do some patient next time, I do some video and then send to you. You can share it with your colleagues. So this is the end point. Okay. And in AP, I don't know whether you can identify. This is the needle. Okay. And we are ending somewhere here, just near the lateral wall. You can see this. This needle, can you see? It's very faint.
Yeah.
Very faint. You can zoom it and see. I don't know. It's difficult for me to also to see. Is it okay? So you need to be somewhere here in this area at the superior medial part of the maxilla. Okay, and just lateral to the lateral wall of the nose. So somewhere here. Okay. So this is your needle. From here it is going. I'm just showing you. I don't know whether you can appreciate that. And then you inject a small volume of dye, contrast. So you know whether it is going in the nasal cavity or not. If it is not leaking in, then you can inject your drug and do, or you can do sensory stimulation if you are planning to do RF ablation. Sensory stimulation again at 50 hertz for sensory, and you should get anywhere between 0.2 to 0.4 volts. You should get some pain or some discomfort at the root of the nose, toward the eye, and sometime in the back. Okay. If you are getting paresthesia on stimulation on the upper teeth, you are stimulating the maxillary branch. If you are getting paresthesia over the hard palate, greater and lesser palatine nerves are being stimulated. So you need to adjust. If you are stimulating the upper teeth, then you need to place your needle little inferior. And if your hard palate is stimulated, then you have to place your needle little superior. So you need to be in between these two. So you do RF ablation, or some people do pulse RF ablation. I am not a fan of pulse radio frequency. I normally do radio frequency ablation, and normally I do for 70 to 90 seconds at 80 degrees centigrade. I do 2 lesions, and usually it is good enough. If local anesthetic is giving good relief, you always do diagnostic test before you go for RF ablation. If local anesthetic is giving good relief in patient, then I go for RF ablation. Here also, because of the oculocardiac reflex, you can have sudden bradycardia. Chances of infection, if you are not taking care that needle is entering the nasal cavity, then infection chances are less. If you are entering the nasal cavity, chances of nasal infection coming in Sphenopalatine foci is very high. Then you have epistaxis. Some people have bleeding. You can easily control it, hematoma formation in the muscle. If you are not too much moving needle in the muscle, you can cause hematoma formation, which is not a big deal. You can control it very well. And lacrimation of the ipsilateral eye because of the unopposed parasympathetic activity. Sometimes it is very disturbing, but usually it is it gets control over time. Then another thing, you have to be careful about glossopharyngeal neuralgia. I'm not going in much detail about this thing, but this is again one of the nerve which is mimicking the trigeminal neuralgia or Sphenopalatine neuralgia. So this is basically ninth cranial nerve. The last 2 or 3 slides, Victor. We have 5 minutes.
Yeah, sure.
Okay. So basically, it has both motor and sensory component. The glossopharyngeal, it supplies the stylopharyngeus muscle, and posterior part of the tongue sensory supply, palatine tonsil and mucous membrane of the mouth and pharynx. And it has a special visceral afferent sensory. It supplies the taste bud of the posterior third of the tongue. So it has little complex supply, sympathetic, the visceral and sensory motor. And so basically it is again a kind of neuralgic pain where it is a shock-like stabbing, typically brief, lasting a couple of seconds, very classical. When somebody is eating something, they start getting this pain. If they are not eating or not talking, they are okay with it. And usually the pain is in the tongue, throat, ear, or tonsil. So they feel that something is in the ear, they are getting shocked. And rare cases, it is bilateral because of some tumor or cancer. And most painful attacks are spontaneous, but maybe still with some stimulus like chewing or speaking or coughing, swallowing, laughing. Okay, now the anatomy is you have just keep this. Okay, so this is a picture from Prithvi Raj. So you have styloid process and you have a glossopharyngeal nerve, and it is very near to the vagus nerve and jugular vein and carotid artery. Okay, so these are important structures which are very near to this. And vagus nerve is again one of the very important nerve when you are planning the block. So if you're planning a block for this nerve, you have to make sure that you are not ablating the vagus nerve. So first, and so there are many causes, like again compression by the vascular loop is very common, and sometimes it can be because of the compression of nerve more distally by elongated styloid process, which can cause pain syndrome, and it is called eagle syndrome. Okay, so infection and tumor can also cause it. So it's a basically clinical diagnosis. You can do MRI, and sometimes CT scan can identify whether it is eagle syndrome, identify the elongated styloid process. Again, pharmacological management is same. We use anticonvulsants and other antidepressants, same as any neuropathic pain. And the first choice of treatment here is microvascular vascular decompression if patient is young. But if patient has comorbidity, they can opt for RF ablation, gamma knife radiosurgery. So this is a small picture. So you can use C-arm to identify the styloid process. So you basically identify, you make a line between angle of mandible and mastoid process. Okay, and a midpoint is usually over the styloid process. Patient is little bit in turning the face on opposite side, and then the midpoint between your angle of mandible and mastoid process is styloid process. Then you go perpendicular and try to hit the styloid process. So if you, in X-ray you can see the styloid process, so you try to hit the styloid process and then withdraw your needle and go just posterior to that. 2 millimeter, once you hit the bone, withdraw, and 2 millimeter go posterior and go deep. And that is where the nerve is lying. You can inject your local anesthetic and you can see whether patient is relieved with pain or not. And if patient's pain is relieved, you can do RF ablation, either pulse or continuous, conventional. I do conventional RF normally. Other intervention I do commonly for facial pain is stellate ganglion block. Very useful in cancer setting because stellate has a lot of facial supply. And sometimes I use acupuncture treatment of cervicogenic headache, which have the facial referred pain. They are also useful. You have to keep in mind the cervicogenic pain generators. So this is it, Victor. So,
well, thank you so much, Dr. Kailash. Questions? There's some questions here in the chat. Anyone can ask directly to Dr. Kailash if you want.
Sure. Yeah.
Or you can ask in Spanish and I can tell, I can translate to Dr. Kailash. Nacho.
Sure.
Victor.
Yes.
This is Rodrigo from Lima. Dr. Kailash, I wanted to ask, for your trigeminal neuralgia, you constantly doing 3 temperature rise during the ablation, or you just do one lesion?
Okay, so basically as I told you, when you, after a good sensory and motor stimulation, start with 65 degrees centigrade or 70 degrees centigrade, whatever you are comfortable with. Do a lesion, give small dose of propofol, do a first lesion, and then you can make patient awake, test, again do sensory stimulation. If your initial stimulation before the lesion was around 0.2 volts, suppose I am just guessing it, if it is 0.2 volt, and after lesion, if you're getting at 0.4 or 0.5 volts after single lesion, I am happy with that, because I need to double the stimulation after the lesion. But if I am getting at 0.3 or maybe 0.25, then I again give some propofol. I do second lesion and then again test it. So till you get 2 or 3 times the pre-op sensory stimulation setting, I keep doing. I have done sometimes 4 lesion also, but you have to make sure that you are not burning too much. So sensory stimulation post ablation is very important. That is your guide where to stop.
I try to raise the temperature progressively in order not to.
So you start with
not
65.
Yeah,
Then
I
you
start
can
with,
second lesion you can start with 70, and third you can do for 75. But normally I don't do go above 75.
above above 35 of 80 is what's recommended. I just try to be safe and do the least temperature that the patient feels the what you just mentioned. I double check the reflex and double check the sensation as well. You use depot steroids or you go for DEXA? I usually do DEXA.
I don't inject steroid.
Okay.
Normally people they use DEXA, but I avoid the injection of any steroid in the CSF. It was very near to the brain. So it's your choice if you want to inject dexamethasone or any other steroid. It's okay.
But, sorry, but you prefer
Thank you, doctor.
non-particular steroid, right? Non-particular.
No,
Sorry?
no particular.
Okay.
No particular plan. Yeah.
Thank you, doctor, very much. I appreciate it.
Thank you.
Dr. Cantisani is asking here about when you send the patient to radiosurgery or surgery.
Okay.
It's an option.
When do you send? Okay, so basically, that in trigeminal neuralgia, when patient comes to you with vascular loop, okay, on MRI, you know that you can give patient different options of treatment. You can give it for surgery, gamma knife, or RF ablation. So normally, what I do, I keep option open for the patient. I give him information about whether what is the advantages and disadvantage of surgery. So surgery is like it's very good. The recurrence rate is very low, but at the same time, it's a major surgery, major procedure. Chances of failure are also there with surgery. It is not that surgery is totally uh, confirmed treatment for this. There are some complications associated with that. Recurrence rate is sometimes there, and patient may not improve even after surgery, and who comes back to us for RF ablation. So these are all chances are there, but surgery is good option in young patients with vascular loop. So we give option to the patient, and we decide about RF ablation and gamma knife. So there are pro and cons with each. So you need to inform and give knowledge to the patient, and then let patient decide what they want to do. So if in vascular loop, but if patient is not having any vascular loop on MRI, then surgical option is usually it's not useful, because what they are going to separate the nerve from.
Agree.
So in those cases, we give option of RF ablation and telling them that surgery is not a good option because there's no vascular loop or anything which is compressing the nerve. So we take patient in confidence and then take a decision. It is not my decision alone. It is patient also who has to involve in decision making.
I have a question, Dr. Kailash.
Sure.
Hi, how are you? It's good to see you.
Thank you.
What are you doing to prevent to anesthesia dolorosa in post-procedure in your patient, for example? Only regulate the temperature, the time doing to prevent this typical complication to treat, you know? What are you doing in your daily practice to prevent this complication?
Mm-hmm. So basically, see, anesthesia dolorosa is most commonly happening because of the overburning of the ganglia when you're doing intervention. If you are doing too much, then it is a problem. So even it's one of the most dreaded complication. I had one patient who came after gamma knife surgery, and she had very bad anesthesia dolorosa. So it's very difficult to manage. So basic treatment is first you have to prevent it. So that is why this method, which is not mentioned in any book, if you read any book, you don't see that you do stimulation, you lesion, and then you again do stimulation to identify how much you have burned. So this is not mentioned. Unfortunately, nobody is teaching that. There are many people who are doing this, but they are not. That is why I want to stress on this fact that when you want to do a controlled lesion, you start low with low temperature, and then you assess how much you have burned after each lesion. It is time consuming. Sometimes patients are old and they wake up little late. So you might have to wait for 10 minutes or 15 minutes between two lesions. But you have to be very patient. If you are not patient, then if you burn the patient nerve 2-3 times without testing, there are good chances that you may overburn. So that is one of the main thing you have to prevent anesthesia dolorosa, because if you overburn, then it is a problem. So lesion, stimulate, check, and then if you need a second lesion, then you go for it. I have done few patients where the lesion was done inappropriately, little less lesion. Patient after surgery also, when he goes to ward, he has some pain, which is not as bad as before, but they still have some pain. I can always take them back and do one more lesion, which is very simple. Usually that is not very painful, because by that time the nerve is already damaged, and when we put the needle, you don't need much anesthesia also. I've done under local anesthesia, the second surgery. So sometimes we need to redo for one more lesion, because important thing is to prevent overburning. So this is the main thing I am doing to prevent anesthesia dolorosa, and I feel I'm quite successful in that. I not a single patient in my clinical practice I got anesthesia dolorosa, luckily. So as a surgeon, you are lucky sometimes not to get complication. If you do enough, you get complication. Okay. Is it okay,
Yo
or you have anything?
tengo
You
una
do anything
pregunta.
else?
Hello,
Yes.
Dr. Kailash. This is Jesus Medina. Nice to see you again,
Hi,
my friend.
Jesus. Hi. How are you? Nice to
Fine,
see you.
fine.
Yeah.
I have two questions. One,
Yeah.
what do you know? Is there anything, or have you ever done any, maybe in cancer and tumor, any phenol or any chemical lysis of the ganglion? And second question, since it is a neuropathy or a certain entrapment syndrome, has there been anything on regenerative medicine for trigeminal? That's it. Nice to
Okay.
see you.
Yeah. Nice to see you too. So first question is, do I use phenol or any glycerol for the thing? So in my practice, I don't use these neurolytic agents. There are two reasons I don't use it, though many of my friends in India, they use it. The first reason is, when you inject liquid, I don't have control on liquid where it is going. So I can only control the dose of the, or volume of the liquid. So I know that I am only injecting over V2 or V1 or V3. If it is all three division, it is okay. You can do injection of liquid and you can ablate all three nerves. But again, I want to avoid V1 division. So once I inject, I don't have control on where the drug is going to flow. That is my main worry. That is why I do more of a RF ablation in my patients compared to phenol or glycerol injection. Okay. That is the reason why I'm not doing phenol or glycerol injection. So I don't do it. But there are many patients who do, people who do it, and they get good result with phenol. They don't inject phenol, but glycerol is commonly used here in India. So in cancer, of course, you can use phenol also. So it's up to your experience and your confidence in what technique you want to use. The second thing is about regenerative medicine. So right now we are not using any platelet-rich plasma or anything for trigeminal now. And I would love to hear if if you're using or somebody is using with it, how you're using it. We are not using it.
No, I have not used it, but I was wondering maybe if you have heard of it.
So only thing I don't understand is this is not a degenerative disease. It is a more of a compressive neuropathy, or it's a inflammatory thing. It is a neuralgia. So we have to think about how regenerative medicine will help in that.
Definitely. Thank you.
Dr. Wendy Rojas is asking a good question. For post-herpetic neuralgia for B1, creo que se desconectó el doctor. Can you hear me, Dr. Kailash?
Creo que se salió pic.
Ok. Vamos a... Le iba a preguntar, le iba a hacer tu pregunta, Wendy. Déjame mandarle un mensaje. Aquí te va. Hello, Dr. Kailash. Can you hear me? Hello?
Yeah, Victor.
Laptop battery has gone down, so I just connected with the. Hi, my laptop battery was down, so I connected with my mobile now.
There's another question, doctor. For post-herpetic neuralgia in V1, so you prefer pulse RF, or what is your treatment?
Okay, so this is one of the difficult situations where you have to take a decision very cleverly. So if it is V1 neuralgia, basically what I do is either I do conventional RF at very low temperature, maybe around 60 degrees centigrade, one or maximum two lesions. And I make sure I keep testing the corneal reflex. This is very important. Keep on checking the corneal reflex. So once you do even at 60 degrees or 65 degrees, that is enough. But pulse oximeter, I am not very convinced with this mode of treatment of pulse oximeter, the pulsed radio frequency. I have not got very good results with pulse, so I don't use it.
And
I do use conventional only, but at lower temperature.
do you increase voltage in some patients? Talking about pulse RF?
Sorry, come again.
Do you increase the voltage in some patients? For example, in this case, V1. Have you?
Okay, the equipment what I have, it check the voltage automatically, so I cannot control the voltage in my machine.
Okay.
So I have limitation, but I think there are variables which you can set, like time. So if you are using pulse, you can increase the time, you can increase the voltage. So these are the things you can do and see what is giving you best result.
Okay. Do you have another question? Any recommendation about mixed pulse and continuous RF? Dr. Walter Osorio is asking that. There's a, do you hear me, Dr. Kailash? You need to your mic is off, Dr. Kailash.
Now, hear me?
Yeah, I can hear you, yeah.
Okay. So, see, pain is very evolving specialty. So we keep do lot of research and variable treatments to see what is giving good effect. So I think you can do a mix of both pulse and conventional RF, but then you have to do a study in two group of patients to see. I have never done it, but I'm not sure how much it will help. Whether pulse, but because many people feel pulse RF has a little different mode of action, electromagnetic waves, and giving effect on the immune cells. So I think you can try that, but clinically how much effective I am not sure. So you need to do and see. I have never done it.
Another question is that if, for example, in V1, you block terminal branch.
Yeah. So you can do that. I have done in few of my patients where V1 was there, and I don't want to do V1 ablation. I do peripheral nerve block at supra and infraorbital nerve block, and I got good results with that. I could relieve their pain by more than 50-60%. They are happy with that. And sometimes I have injected even phenol. There I have injected phenol in supraorbital and alcohol and phenol I've injected there.
So how much ml?
It's 0.1 to 0.2, not more, because the area is very small.
Yes.
Very,
Yes. Mhm. Okay. Another question. A patient who has already 2 RF, trigeminal neuralgia, and then gamma knife radio surgery, and after that, patient is still with pain.
okay, so these are the patients where you have to rule out possible neuropathy. So you cannot keep on doing intervention or surgeries one after another. So these patients normally they develop neuropathy. So neuralgia and neuropathy, these are two different things. So if you have neuropathy, it is very difficult that your surgical or interventional thing may help the patient. So here I take help of my orofacial pain specialist. So we have in our team Dr. Sood, you know her, I think. So she does a lot of treatments like a low grade laser or psychological treatment and other things she is master in, and these patients really do very well. These patients you have to find out why these procedures are failing, whether it is because of some other pain generator other than trigeminal neuralgia nerve which is causing pain, or a nerve itself is gone in neuropathic and that is why it's not responding. So this is you have to find out. These are not simple cases. So important to find out pain generator, and then rather than intervention, take help of your orofacial pain colleague. So, but if you are convinced that it is neuralgic pain, it is coming from trigeminal nerve, you can always do diagnostic block, see the response, and then you can go for. In trigeminal, I don't do diagnostic block very often, but in very complicated cases, before doing ablation, you can always do a diagnostic block and see whether patient respond or not. If respond, then you can go for it. Is it okay?
Thank you. Regarding age, for example, a young patient versus aged, I don't know, 65-old patient, do you have some different treatments? Your choice of treatment is different? For example, pulse RF, continuous RF, I don't know.
No. As far as RF is concerned, I always I am convinced that pulse RF is not useful. I don't use in my practice for trigeminal nerve. But in young patient, if they have vascular loop, I always tell them to meet a neurosurgeon so that they listen to that surgical side also. They understand what is the advantage of surgical side, what is the disadvantage, and what is advantage of RF. Then they take conscious decision. We don't force them to go for RF ablation because there's some complication like numbness of the face. They may feel for a few months to maybe continuous numbness, which they are annoyed with. So once they take conscious decision that they want to go for RF with these complications which are unavoidable like numbness of face, then we do RF ablation. But if they don't want this complication, they go for surgery. So at least they are informed what treatment options they have. In old patients, most of these patients, they have comorbidities. The risk of open surgery is very high, or even endoscopically now people are doing, the risk is very high. So we give them option and make them make case for RF ablation more commonly. We are doing that in older patients.
Okay.
Though it's a very low grade surgical intervention compared to open surgery. Yes. Or MBD.
Okay. ¿Alguna otra pregunta? ¿Alguna otra other question?
I can see Dr. Ignacia. How are you, Ignacia?
Sorry?
I can see your friend Ignacia.
Ignacio Reyes.
Yeah, it's there. Yes.
Oh,
how are you?
Fine. Thank you. It's good to see you again, man.
Yes.
Well, thank you so much, Dr. Kailash.
Thank you.
Very happy with your lecture.
No, definitely. I am also happy after we are planning this for very long.
Yes.
Hopefully everything is good at Mexico in this lockdown. I pray for everyone's safety. Be be at home and be safe.
Take care too. Take care,
Okay.
doctor. Gracias
We'll
a
talk
todos.
again.
Thank you.
Thank you very much.
Bye-bye, everyone. Bye-bye.
Good morning to you. Muchas gracias. Se grabó la plática, entonces voy a dejar mi correo en el chat y me envíen el correo, por favor, los que quieran que les envíe la plática. Y la siguiente semana vamos a tener alguien más, no recuerdo quién nos va a acompañar. Pues seguramente también va a estar interesante. Muchas gracias a todos que se tomaron el tiempo de la hora de la noche.
El martes de la próxima semana vamos a tener a Ana Schwarzman con el tema de ultrasonido en columna lumbar, me parece, abordajes en columna lumbar, por ecografía.
Qué bueno.
Perfecto. Creo que por aquí está Ana, ¿verdad? Por ahí la vi. Creo que por aquí está Ana, ¿verdad? Saludos, Anita.
Sí, por ahí estaba.
Saludos, Anita. Pues sí, muchas gracias por estar ahí al pendiente de las... Muchas gracias por estar ahí al pendiente de las... podemos aprovechar estas noches de encierro.
Oye, y yo creo que esto, pasado el encierro, debería continuar.
De acuerdo. Sí, creo que esto es algo que nos ha dejado esta cuarentena, ¿verdad? Algo que podemos comunicarnos entre países.
Muy bien, Víctor. Felicidades.
Estamos comunicando, nos dieron una plática ahora sí que del otro lado del mundo.
Y en otro horario.
Y en otro horario.
Así es.
Bueno.
Los arquivos.
Saludos.
Un gusto de verlos.
Gracias.
Cuídense mucho.
Cuídense, muchachos.
Gracias, cuídense.